Hey guys, this is episode 1 of the Doc Talk. My name is Curtis Rhodes. I am the paramedic instructor out at Gordon Cooper Technology Center here in Shawnee, Oklahoma. I am sitting with Dr. Melissa Brave. She is our medical director as well as a 20-year paramedic in the field. She has transitioned to the emergency room medicine. Go ahead and say something, Dr. Brave.
Pleasure to be here. I'm hoping that we learned quite a bit.
All right, let's get started. So we know as paramedics and EMTs and even EMRs that airway is a big deal. So we're going to talk obviously about some advanced airway. As you can see by the screen, we're going to talk about RSI, but let's go ahead and get into the nuts and bolts because I know there is some really important pieces of RSI, and let's talk about the way I like to put it is we want to set ourselves up for success. So what, in your opinion, Dr. Brave, how do we do that? How do we set ourselves up for success?
I think that you have to be very systematic about the way you approach each airway and prepare for the worst, but expect the best, right? So that's where we get the P's. We're walking through these using that acronym or the positioning, preparation, and kind of walking through each step as you should think of it each time that you tackle an airway.
Yeah, so really building that system is what you're saying is
Right.
at the beginning of our initial training, we're really building that system, much like a patient assessment, to where you're doing something repetitively over and over and over and just have that systematic approach.
Right. Consistency, kind of practicing, making sure that you think of every possible way that it could go wrong and preparing for that. And then, every patient, every time, and you get pretty consistent results that
Yeah,
way.
got it. Okay, well, let's jump off into this.
All right, so how about preparing and positioning? Those kind of go together. One of the things I say is prepare, make sure we don't get somebody paralyzed or sedated and all of that before we have our suction. We plan our medications, backup airways, backup ventilation devices, and then, of course, bare bones at the very end of it, you'd have to have a surgical airway. So that's one of the things I think that when we get into RSI or any airway, in any case, people think, if you have to perform a surgical airway, that's the worst thing that can happen because your skill's poor or something like that, and that's actually not the case. And I mean, I've had at least 3 over the last year that we've just reversed in the hospital because we had some equipment. We were able to gain that airway, but the patient didn't suffer an anoxic brain injury.
Okay.
So you have to make sure that you prepare for that as well. So the other thing is positioning. Positioning is key, making sure that we get our patient in the appropriate position. I stole this picture offline just because I thought it was a great utilization of the way that they use the bed and the way that they position the neck. Obviously, in a trauma, you couldn't do this, but
Yeah.
but the other thing is that line there kind of gets you cognitively to where that ear is either at the level of the shoulders or above.
Yeah.
So
Yeah. You know, as a brand new paramedic, it took many years for me to realize this. As a brand new paramedic, I went with my findings, meaning however I found the patient, I worked on him there. I didn't, you'll hear me repeat this over and over, but setting myself up for success or setting yourself up for success. What I realized once I became more comfortable as a paramedic is we could move the patient into a better position. We could move them off of the ground onto the cot and do the thing there. We could put them into the back of the truck. All of these different things, but managing the airway in a way that maintains it, but then setting ourselves up for success to be able to visualize properly. As a brand new paramedic, I was always anxious and excited and just had to hurry. But we know that's not the best way to do these things.
And your biggest mistakes are made in a hurry.
Absolutely.
That's one of the things I try to teach.
Absolutely.
Don't be rushed. Make sure you will spend less time working on an airway if you just take those steps.
Yeah.
Position your patient, making sure you're in the right position, making sure you have all your equipment. It's worth taking the time.
Yeah.
For sure.
I mean, I would say this is probably one of the biggest tricks, but also tips of airway management is this proper positioning. Would you agree?
Yes.
Yeah.
Absolutely.
Yeah.
So then let's think about pressure. This is new. This is not what you're typically taught as your P's for intubation or RSI. But you have to think about pressure. Many times we'll get this patient intubated and very shortly thereafter they'll go into cardiac arrest. And what we've learned is that if you take somebody from normal ventilation where their diaphragm contracts and pulls down and air pulls in, and that also is a way of supporting hemodynamics.
Right.
So if you take them and you put a tube in and then you start pushing air into the lungs, you change that. If I took you just for fun and then intubated you, your blood pressure would drop probably 10 to 20.
Okay.
systolic. You would change, you would equilibrate because you're healthy, you don't have anything going on. But in your not so healthy patients, you start out with a blood pressure of 60.
Right.
You will kill them if you intubate them.
Yeah.
And I think that cognitively we need to say airway first, except if you have a low blood pressure, we need to treat that. And one of the ways that we've learned to treat that is our push dose, what we call push dose pressors. Epi is the ideal medication in the field because the others we don't deal with enough, and dosing errors can be an issue. So essentially you just take an ml of that code card Epi, you dilute it in 9 mLs of saline, and then you've got your mixture. You give an ml to 2 mLs at a time until your blood pressure's above 90.
Okay. And then you move on just as if
you
you're
can intubate.
starting over.
Yeah. And then you've got some at the bedside, so after you intubate them, if they tank a little bit more, you can always give a little bit more.
Yeah, it's an interesting thing that's changing in our industry over just the last couple of years is this push dose Epi or push dose pressors.
Right.
Because you're able to fix something at a much faster rate immediately rather than trying to hang something and all of these things.
Right.
You're able to just push 1 ml of fluid and potentially now move on with your airway.
Right.
Where in the past we were unable to do that.
Correct.
If you're critically thinking your way through it.
And these people may still need a little fluid and things like
Sure.
that, but that takes time.
Yeah.
And you don't have that time, so this is the way to put a little bandage on it until you can get them taken care of.
Yeah.
For sure.
Good.
Yeah. And then you have to think about pre-oxygenation. One of the things that you don't want to do is if you have someone on CPAP and they're failing, it's time to intubate, you don't want to just hurry up and pull that off. Leave the CPAP on, put nasal cannula, put also a non-rebreather, just flood them with as much oxygen as you possibly can. You can also give them what's called the 8 vital capacity breaths, which washes out the nitrous and usually gets you to as close to 100% as you possibly can get.
Okay.
So if you've done that and you're not at 100%, then you just know your patient doesn't have a good reserve, and this is the best you're going to get.
Okay.
So, and the other thing I like to talk about is passive apneic oxygenation. It's been out. It is controversial, but it's not harmful, and in some patients it is helpful. Patients that it is most helpful are patients without coexisting lung disease.
Okay.
And so those are the patients with traumatic brain injuries, patients who maybe have overdosed, things like that. It tends to be more helpful in that situation.
Yeah, I was looking into this a little bit prior, doing some more reading on some of the research and the studies, and found a lot of, as in anything in EMS, just like your airway, you can find research for and research against.
Correct.
But with this, the thing that was against, basically all they were saying was, this isn't the miracle thing that maybe
Right.
some people think
Right.
it is. Nobody that I read found anything harmful. You
Yeah.
know, it just allows the body, to me, it's just interesting the body holds on to that O2 because of the air pressures, you know, being absorbed and all of the things that go on with that. It's just interesting, and we're rushing around, working as fast as we can when if we can slow down. So if nothing else, just slow down a little bit. Then we don't have to worry about broken teeth and all these things by just slowing down.
We call it rapid sequence intubation. That's kind of an oxymoron. There's nothing rapid about it. It's a systematic, methodical method of gaining an airway.
Yeah.
The other thing to consider is a supraglottic airway to maybe ventilate and oxygenate that patient for a period of time, even before you intubate them. So some of my patients, I put in LMAs, and then I'll bougie through that after I get their oxygen up, and the transition's fairly seamless. So there's all of those options to get that oxygen up. But just remember, you may get to 90, and that's just the best that patient's going to get.
Right. That's a pretty good day for them.
For sure.
Yeah.
And then let's talk about pretreatment. Pretreatment is the medications you give before you give the paralytics. Pretreatment is what we do to kind of blunt responses to what we're about to do to the patient or prepare the patient for successful intubation. Fentanyl is my all-time favorite. We need to become very, very familiar with this drug. It's out on most ambulances. It tends to be the go-to narcotic medication, and so it's there, and let's use it. So one of the things it is it's a sedative and it's a pain medicine. So if we treat pain, what we found is that if we treat pain ahead of time and we really get control of that, we can use less sedation. Patients come off the ventilator quicker, their mortalities go down, their length of stay in the ICU goes down. All of these are good things. And so if we can start that in the pre-hospital arena, that's fantastic. Fentanyl actually blunts that intracranial response more than lidocaine. Lidocaine's a 50-50.
Okay.
So I don't even think it's worth it.
Right.
If you're using the fentanyl, there's no need to use lidocaine,
Okay.
even in your traumatic brain injuries. Atropine should be at the bedside. Atropine kind of fallacy is that we should pre-treat kids before we give them, but we found out that that's just not true.
Right.
You should have it ready, but most of them don't typically need it. And then there's I don't know that ambulances typically carry glycopyrrolate. It's just a version of atropine that doesn't penetrate the blood-brain barrier, but it'll dry them out real quick. But you do carry Benadryl, which works very similar to it as far as drying them out. Okay. So if you have a lot of secretions or you're noticing a lot of secretions, you might go ahead and hit them with a little Benadryl.
Yeah. Okay. Yeah. Good to know. Yeah.
Paralysis with sedation. Now let's talk about the sedative. This is the thing you want to give the patient. You know, if your patient just ate down a bottle of their Klonopin, that's the reason you're intubating them. If they're sedated, you can move on to paralysis, right? Right. So one of the things that we go through is, what is the best sedative? Ketamine's kind of the rave right now. Mm-hmm. It's fine. It's kind of expensive. It's not much better than etomidate, truth being said. One of the things that we need to understand is that all the drugs that you guys use are cardiac depressants, all of them including ketamine. Ketamine has some catecholamine surge, which is helpful. It does not cause increased intracranial pressure. So etomidate and ketamine have the same indications, contraindications, right? So one of the times I wouldn't use ketamine is if I have somebody who's profoundly tachycardic and I'm having an issue with that. Okay. That would be it. Versed, I would say reserve that for last resort. We're trying to stay away from the benzos, even in our alcohol withdrawal patients. We're typically using different medications because we can get them, again, increases ICU delirium, increases mortality, all of those things. So we're trying to stay away from that. So if I were to go to, I would say get your etomidate, get your ketamine, and fentanyl is in there as well. Okay. So, yeah. So there you go.
Okay. That's paralysis.
So when we talk about paralysis, everybody always gets that big speech that succinylcholine is the preferred paralytic. It's cheap sometimes, but you need to know all of them because at some point one of them is going to be on back order. You're going to have to use the other one. Succinylcholine is the preferred RSI medication if I'm taking you electively to do something. If when you wake up you have a better airway. But I don't know about you, Curtis. If I RSI'd someone in the field, they didn't wake up with a better airway.
Right, no, typically not.
So if you didn't get it this way, you were getting it surgically, and that's just the way it is. Right. So overall, there are some contraindications to succinylcholine that need to be kept in mind. For that, I usually say if you can use Vec or Rock, preferably, and replace Sux when one of those is on back order. One of the things is your cholinergic overdoses. They'll be paralyzed forever. You know, the enzyme that breaks it down is now bound up, and so you're fighting that. I certainly wouldn't paralyze them with Sux. The other thing is you know, anybody who a small bump in potassium might kill them. You know, your end-stage renal disease patients, somebody who you think is hyperkalemic, and then those with neuromuscular disease. And again, they'll just be paralyzed forever. Yeah. So it'll also cause their potassium to go up threefold. Okay. Yeah. Yeah, that's good to know. But the Vec and Rock, rarely any contraindications. Right. They'll be paralyzed for long periods of time. And then your patient population is very narcotic dependent, and basically they're not opioid naive, and it's going to be very, very difficult to keep them sedated. You're going to have to paralyze them again. Yeah. So it's good to have something that's going to last for that trip. It's going to last, yeah. Rather than a rapid onset and a rapid duration. Right, and then you're fighting somebody with a tube in, and that just becomes difficult. Yeah. Not the best place to do that in the back of an ambulance. Not at all. Or a helicopter. So I didn't go over a lot of dosing because I just, you know, any way you can cognitively offload is huge. You know, you have a lot to do, and does it pass the 3 o'clock in the morning test, right? Right. Can I do this at 3 o'clock in the morning with very little sleep? If you use some of these guides, so one of the services that I help manage, we use the Rappi tube because it was in their RSI box, and they dosed on that tube, that tube system. So it's just a little cardboard thing that slides in and out, picks your patient weight, and all your doses are done for you. Gotcha. So there's no dosing errors. Yeah. Right? Or you can use Palmium and Critical both have great apps that you can plug the patient weight in, and it doses everything for you for your RSI meds. So I get no reimbursement from these people, but these are wonderful devices. And if you can save yourself some headache at any point in time, just do so. Yeah. And Rappi Tube has an adult and pediatric side. So does Critical and Palmium. They're all both great. Yeah, that's good because, so 20 years ago when we went through paramedic school, it was a big deal to have everything memorized, right? That was like, I'm legit because I've got every epidose memorized to the microgram, the milligram. I've got dopamine. I can do the clock. I can do the wheel. All these things. It's the same time as when we were using our watches to do the drip chambers, right? Exactly. Yeah. Now, recently, some of the new words you're hearing is a culture of safety. Yes. So what we're talking about is making sure every dose is correct and appropriate. Right. So there is, I'm not sure if you're aware of this, we've not spoken of this before, but in Australia, who has a
one of the leading EMS service cultures in the world. They have such a culture of safety with medication. They have their patients sign off on medications, meaning this: they have a printed out paper with all of their meds. It's laminated. If I remember right, it's laminated. They hand it to them and say, "This is what I'm giving you. This is how much I'm giving you. Do you agree?" The partner looks at it, the patient looks at it, and then they give it. As you can imagine, there's very, very low medication errors.
Right.
So that culture of safety is something newer to us, and eventually we're going to get there.
Right.
But it's good to see the pride is going away of memorizing everything and using our resources.
Right.
You know, that's one thing that I always think paramedics are good at, is using our resources. But we're very prideful, and you've seen them. Guys won't give up the airway.
Yep.
They're not using their resources.
Right.
Because they won't go to a supraglottic airway because I'm going to get this tube, and that's what I do. You know, and there's certain areas in this job that we need to be better at.
There's one thing called pride, and there's another thing called murder.
Yeah,
so we don't want to intubate someone.
That's right.
To death.
We don't want to cross that line.
Yeah, we don't want to cross that line. The other thing is that I cross-check my doses. I'll have a nurse. I'm saying I'm giving this much for this kid. And we have a computer system that helps check that.
Yeah.
But at the same time, hey, this is how much I'm giving. Make sure we double check this.
Yeah.
You know, and always
it's important.
It's not a habit that even nursing staff gets into all the time, but it's a habit that I try to force of, we're going to start this, you know, especially if it's a pediatric patient on this Versed trip. Okay, this is what we're going to do, but have someone else take a look at this pump before we hit the start button. Yeah. You know.
It's very easy to make a mistake.
Correct.
Doesn't mean that you're horrible, but it means it does mean something if you don't recognize it or you didn't take the time to make sure you're doing it right.
Right.
There's the mistake. There's the real mistake.
Exactly. We're human. We're going to make mistakes.
Absolutely.
The key is to create a safe system.
Absolutely.
Yeah. So now what we've all been waiting for, you know, we love intubation. I mean, I love intubating. We just have to get the tube in, right? So placement. You want to confirm it by watching it go through the cords. Continue. Now, we all know that we don't all get the best view of the cords, okay? Sometimes we just watch it go above the retinoids.
Somewhere.
You know,
you
sometimes we just see the esophagus and we don't put it there. You know, either way, you're visualizing something, and continue to monitor that. Breath sounds are notoriously inaccurate. I will get people to say that they have breath sounds. Yeah, I hear breath sounds. Even in the hospital, we have people who will be intubating us. I have breath sounds. They don't have breath sounds. You see the gut rising and falling, and you're like, no, they have sounds, but those aren't breath sounds. So that's where your continuous capnography is coming. I mean, that's just a wonderful tool, and you should be using it. It fails sometimes. Sometimes the machine doesn't work. That doesn't mean you have to yank tubes out, which are good. That's why we have, you know, more than one option of placing a placement confirmation. So, but and then so tube location is the next thing. Notoriously, I get patients who come in who've been intubated, and I mean, just barely the tip of the tube is sticking out because they were not going to lose that tube.
Right.
And that gets a lot of chest tubes.
Yeah.
Now, I like putting in chest tubes, but if you look back, you know, take a second, take a deep breath, you've got the tube in, you've got it secured, and you realize it's so deep.
Yeah.
You know, a good rule of thumb is about 23, 24 centimeters is deep enough for anyone.
Yeah.
I don't care if you just intubated Shaquille O'Neal. I mean, that's deep enough, you know. So look at your numbers and kind of play around with that and make sure you do have good breath sounds in all your fields.
Yeah.
So, and then secure your tube and bring them in and be successful and be proud.
Well, I know many times when I've tubed somebody, I can hear breath sounds in the belly and not hear breath sounds, and it's a good tube. I mean, I think I don't know what causes all of that, if it's just the way the sound waves move or whatever, but many times you can hear breath sounds in the belly very easy. And it makes me wonder, anatomically, maybe the esophagus is just much closer, you know, or maybe the diaphragm's not.
Well, I mean, and think about where your ultrasound probes work the best in the belly because of the fluids and conduction of sound. It really has to do with that. And the fact is that we can hear lung sounds and we can hear them everywhere. And we really can't differentiate where they're coming from.
Right. Yeah.
And then post-intubation. Now, we can do a whole talk on this and will, but one of the things that I'll plug in here, because this is a short segment, you want to continue to examine your patient, continue to watch their blood pressure. This is not the end. In some cases, this is just the very beginning of getting someone oxygenated, and there are some issues that might come up. Continue your waveform capnography and continue post-intubation sedation. And those are kind of the keys just to touch on near the end of this talk.
Yeah, okay.
Yeah. right.
Okay, well, we've covered a lot of ground, especially for episode 1. So thanks, Dr. Brave. I've enjoyed it. I hope you guys have enjoyed it. Once again, this is episode 1 of our Doc Talk, and we'll catch you guys on episode 2.